Good morning. Welcome to this podcast on heart failure, part 1. I'm Dr. Murphy, Professor of Anesthesiology at the College of Medicine, University of Kentucky. The suggested reading for this podcast is primarily Stelting's Anesthesia and Coexisting Disease, 6th edition. This chapter, authored by Dr. Popescu, provides all the essential information on this topic, and supplemental information should be sought by reviewing the 2013 Guidelines for the Management of Heart Failure. Regarding the content outline, you'll see that the topics here include heart failure and cardiomyopathy, right and left ventricular dysfunction, signs and symptoms, systolic versus diastolic dysfunction, and treatment of heart failure. This podcast will not go into depth in all these topics. However, you should include them in your self-study. After viewing this podcast, you should be able to define heart failure, classify heart failure, explain the pathophysiology of heart failure, locate published guidelines for the management of heart failure, and after viewing part 2, you should be able to discuss the anesthetic management of patients with heart failure. First, heart failure is a complex pathophysiologic state characterized by the inability of the heart to fill with or eject blood at a rate appropriate to meet tissue requirements. Symptoms of dyspnea and fatigue and signs of circulatory congestion and/or hypoperfusion are the clinical features of the heart failure syndrome. This slide summarizes the epidemiology of heart failure. Take-home points here would include the fact that systolic heart failure is more common among middle-aged men because of its association with coronary artery disease, and that diastolic heart failure is usually seen in elderly women because of its association with hypertension, obesity, and diabetes after menopause. Heart failure is a clinical syndrome. The primary pathophysiologic feature is the inability of the heart to fill or empty the ventricles. It is usually, or most often, due to, as a result of impaired myocardial contractility caused by ischemic heart disease or cardiomyopathy, or cardiac valvular abnormalities, hypertension, diseases of the pericardium, or, in the case of the right ventricle, pulmonary hypertension. The most common cause of right ventricular failure is left ventricular failure. Heart failure has been described in various ways: systolic and diastolic, acute and chronic, left-sided or right-sided, high output or low output. Ultimately, however, all forms of heart failure are characterized by high ventricular and diastolic pressure because of altered ventricular function and neurohormonal regulation. Systolic heart failure has many causes, and you should remember that coronary disease typically results in regional defects in ventricular contraction, which may become global over time, whereas all other causes of systolic heart failure produce global ventricular dysfunction. This slide simply summarizes the causes of systolic heart failure. Now, systolic heart failure is characterized by a decreased ejection fraction and is closely related to the increase in diastolic volume of the left ventricle. This slide from Stelting's Anesthesia and Uncommon Diseases summarizes the various causes of left ventricular dysfunction, the body's attempt to compensate by remodeling, the resulting low ejection fraction, and the development of chronic heart failure with pump failure and the typical symptoms of heart failure. Diastolic heart failure is usually characterized by a normal ejection fraction. However, all patients who have systolic heart failure have diastolic heart failure, or diastolic dysfunction at least. Diastolic heart failure can be classified into 4 stages. The first stage, or class 1, is characterized by normal left atrial pressure and escalating to classes 2, 3, and 4. There's a abnormal relaxation of the left ventricle and reduced left ventricular compliance, which results in an elevation in left ventricular and diastolic pressure. To compensate for the increased left ventricular and diastolic pressure, the pressure in the left atrium increases so that left ventricular filling can occur despite this increase in left ventricular and diastolic pressure. The main factors that predispose to decreased ventricular distensibility include myocardial edema, fibrosis, hypertrophy, aging, and pressure overload. The most common causes of diastolic heart failure are ischemic heart disease, long-standing essential hypertension, and progressive aortic stenosis. This table from Stelting's Anesthesia and Uncommon Diseases compares diastolic heart failure and systolic heart failure. Our understanding of the pathophysiology of heart failure is an evolution. However, it's well known that the initiating mechanisms of heart failure can be resulting from pressure overload, such as aortic stenosis, volume overload, such as valvular regurgitation, myocardial ischemia or infarction, myocardial inflammatory disease, or restricted diastolic filling as a result of pericardial or myocardial disease. The Frank-Starling relationship describes the increase in stroke volume that accompanies an increase in left ventricular and diastolic volume and pressure, as shown in this cartoon, and which should be quite familiar to you from your studies in physiology. Stroke volume increases because the tension that is developed by contracting muscle is greater when the resting length of the muscle is increased, as occurs with increased volume in the ventricle. As well, constriction of venous capacitance vessels shifts blood centrally, increasing preload and helping to maintain cardiac output by the same Frank-Starling relationship. The magnitude of the increase in stroke volume produced by changing the tension of ventricular muscle fibers depends on myocardial contractility. When myocardial contractility is decreased, as occurs with heart failure, a lesser increase in stroke volume is achieved relative to any given increase in left ventricular and diastolic pressure or volume. In other words, you're at the flat part of the curve. And interruption of this vicious circle is the purpose of many current therapeutic strategies for heart failure. A decrease in renal blood flow due to low cardiac output activates the renin-angiotensin-aldosterone system, which increases renal tubular reabsorption of sodium and water. And although heart failure is associated with sympathetic activation, there is in fact a downregulation of beta-adrenergic receptors. Therapy with beta blockers is aimed at decreasing the deleterious effects of catecholamines on the heart. So while beta blockers at one time were considered to be contraindicated in heart failure, as you are well aware now, they are part of the management. Regarding the inotropic state of the heart, the maximum velocity of contraction is referred to as Vmax. When the inotropic state of the heart is increased, as in the presence of catecholamines, Vmax is increased. And conversely, Vmax is decreased when myocardial contractility is impaired, as in heart failure. In heart failure, tachycardia would be an expected finding and would reflect activation of the sympathetic nervous system. However, in diastolic heart failure, tachycardia can produce a decrease in cardiac output resulting from inadequate ventricular relaxation and filling time. Therefore, it is felt that heart rate control is an important goal in the treatment of diastolic heart failure. The afterload presented to the left ventricle is increased in the presence of systemic arterial constriction or hypertension, and the administration of vasodilating drugs can increase forward left ventricular volume in patients with heart failure. So, in the heart failure syndrome, the heart evolves into an endocrine organ. Both ANP and BNP inhibit cardiac hypertrophy and fibrosis and therefore limit remodeling. The response to elevated levels of endogenous natriuretic peptides is blunted over time in heart failure. However, the administration of exogenous BNP can be useful in the treatment of acute heart failure. Myocardial remodeling is a result of the various endogenous mechanisms that the body uses to maintain cardiac output. One thing to remember about myocardial remodeling and chronic pressure overload is that hypertrophied cardiac muscle functions at a lower inotropic state than normal cardiac muscle, despite the increase in mass. Also regarding myocardial remodeling, the angiotensin-converting enzyme inhibitors and aldosterone inhibitors have been proven to promote a reverse modeling process. Therefore, they are indicated as first-line therapy for heart failure. The signs and symptoms of heart failure. probably are quite well known to you. Dyspnea reflects the increased work of breathing caused by stiffness of the lungs produced by interstitial pulmonary edema. Orthopnea reflects the inability of the failing left ventricle to handle increased venous return associated with the recumbent position. And finally, paroxysmal nocturnal dyspnea and wheezing are caused by pulmonary congestion and sometimes are referred to as cardiac asthma and are accompanied by radiographic evidence of pulmonary congestion. Other signs and symptoms of heart failure include fatigue, weakness with minimal exertion. Heart failure patients may also have anorexia or abdominal symptoms, and decreases in cerebral blood flow may produce confusion, difficulty concentrating, insomnia, anxiety, or memory deficits. The classical physical findings of patients with left ventricular failure are tachypnea and the presence of moist rowels. The finding of a resting tachycardia and a third heart sound, or S3 gallop, or ventricular diastolic gallop, is another physical finding. Severe heart failure may manifest as systemic hypotension with cool and pale extremities despite vasoconstriction, or as a result of vasoconstriction. It's the important point here is to recognize that despite vasoconstriction, blood pressure may be low. A narrow pulse pressure with a high diastolic pressure reflects a decreased stroke volume in many patients. Right-sided heart failure can be seen or associated with jugular venous distension and or the hepatojugular reflux finding on physical exam. Pleural effusions may be found, often right-sided. And bilateral pitting pretibial edema is typically present with right ventricular failure and reflects both venous congestion and sodium and water retention. Moving on to laboratory tests. Complete metabolic profile should be obtained in the evaluation of patients with heart failure. In questionable cases, the use of serum levels of BNP and its associated N-terminal fragment pro-BNP can be used to differentiate causes of dyspnea. The interpretation of BNP levels, however, does require clinical context. The EKG has low predictive value for the diagnosis of heart failure, while the chest X-ray has typical radiographic findings of Curley's, A, B, and C lines, alveolar edema, butterfly pattern, and it's well known that pulmonary congestion on chest X-ray may persist for several days after normalization of cardiac filling pressures and resolution of symptoms. Echocardiography is an extremely useful tool in the management of heart failure. And two-dimensional echocardiography coupled with Doppler flow studies can help determine whether or not there are abnormalities of the myocardium, cardiac valves, or pericardium. Heart failure is classified as class 1, 2, 3, or 4, and the levels of exertion which cause symptoms is displayed on this slide. In 2005, a guideline update introduced stages of heart failures, and stage A, B, C, and D were described. This way of describing heart failure and classifying it was found in the practice guideline. With respect to the management of systolic heart failure, the major classes of drugs for medical management of systolic heart failure include inhibitors of the renin-angiotensin system, beta blockers, diuretics, digoxin, vasodilators, and statins. Most heart failure patients are treated with a combination of drugs, and it has been shown that therapy with ACE inhibitors or beta blockers favorably influence long-term outcome. This overloaded slide is a reproduction from those guidelines, and when you review the document itself, you may find some interesting aspects about the management of heart failure, but I will not go into them in detail on this slide. So what's interesting in the guidelines? Well, I'll extract a few things which I found interesting, and even at this point in time, the venerable old drug digoxin is felt to be potentially beneficial in patients with heart failure and reduce ejection fraction to reduce hospitalization, to decrease hospitalizations for heart failure. Another class of drugs which are used include beta blockers, and a target dose based on large clinical trials has been identified, and interestingly enough, extended release metoprolol has a target dose of 159 milligrams per day. So what else is interesting? Although statins may be used commonly in patients with heart failure, there's no benefit, no class 3 recommendation. What else is interesting? ICDs are highly effective in preventing death from ventricular arrhythmias, but frequent shocks decrease the quality of life and may lead to post-traumatic stress syndrome. So the decision to implant the ICDs may be an evolution. The complex decision about the relative risks and benefits of ICDs for primary prevention of sudden cardiac death must be individualized for each patient. What else is interesting in the guidelines? Well, common factors that precipitate decompensation include non-adherence to regimens, acute myocardial ischemia, uncorrected high blood pressure, atrial fibrillation, and other arrhythmias. The addition of negative inotropic agents such as verapamil or nifedipine, or even beta blockers, although they are indicated in the treatment of heart failure. The acute pulmonary embolus, or perhaps even chronic pulmonary emboli, drugs that increase sodium retention, alcohol use, endocrine abnormalities, infection. So there are many recognized entities which precipitate decompensation. So further, what else is interesting in the guidelines? Well, it's interesting that they consider that low-dose dopamine may be considered in addition to loop diuretics to improve diuresis and preserve renal function. Maybe this is a recommendation which will fall by the wayside, but currently in these guidelines suggest that low-dose dopamine may be used in this circumstance. Other medications which may be used in hospitalized heart failure patients include some of the common ones like nitroglycerin, and the more toxic ones like nitroprusside, and the ones which are now passé, such as Nesratide, which is BNP, exogenous BNP. Well, this concludes the podcast part 1, and I thank you for your attention.